coming for this mini med school series. I just want to say three quick things before we get started. First, my name is Mohanish Deshmukh. I'm a co-director of the UNC's MD PhD program. We have Allison Regan, who's the assistant director of the program. This series is entirely put together by the students, awesome students of our MD PhD program. So I want to, and by the way, if you don't know this, this is a combined MD and a PhD program. We recruit students from all over the country. They're in the program for some period of time, and they graduate with both an MD degree and a PhD degree. Just wonderful students. And so a big shout out to there's Matthew at the back and Paige, who are co-leaders of the mini med school program, but also their team over there. I can see Amber, Monica, Tuba, and Anna. So let me just thank them for organizing this right now. The second quick thing I want to say, I mean, of course, very appreciative for the speakers today. Kyle's going to be introduced. We have the chair of our neurology department, Dr. Gwenn, who herself is an MD PhD, and she, Monica will, or Paige will introduce her later. Second quick thing is, this is really what is the point of this? This is really the point of this is to engage the community. You know, this is health and disease is important to all of us, and these students have come up with a wonderful way to engage the community on these topics. There are 5 topics this year. You would have seen and read about them. Please come for all of them if you can. They're on every third Tuesday till May. There are people on the Zoom, but we appreciate you taking your time, and so welcome.
Monish already kind of introduced us, but my name is Paige, and Matthew is in the back doing all our technical work. We're 4th years in the program right now, so still a ways to go, but happy to be helping to host this year. And if you have any questions, feel free to talk to either of us or any of the other people helping today. Now I have the pleasure of introducing Kyle Pellegrino, who is going to be our student speaker tonight. He's also a 4th year in the program. He's originally from New York and completed his BS in neurobiology and behavior at Cornell University, where he started doing research in the neurocircuitry related to depression. After completing his bachelor degree, he then did a post-bac at Rockefeller, where he studied neurocircuitry related to metabolic regulation. And with that, give it away to Kyle.
Hello. All right, so thank you all for coming out here. Monish did a great job introducing this. Paige, thank you for the introduction. So thank you everyone in person and on Zoom. As Paige said, my name is Kyle Pellegrino, and I'll be kind of kicking off our lecture series for mini med school. I'm a 4th year MD PhD student, and my research focuses on neuroinflammation and the mechanisms that lead to the progression of Alzheimer's disease. And so I'll be giving our talk on Alzheimer's disease and dementia. So as a little plug, here is just that schedule that Monish was referring to. So we have talks every 3rd Tuesday of the month. And next month, it'll be on outdoor health, then on weight loss and diabetes, then sudden cardiac death, and finally with ultrasound. If you do come to 3 or more in-person events, you do qualify for some free swag. So feel free to keep coming. It's a great time. And maybe next time we'll have snacks. I don't know. Stay tuned. So here's just a little brief outline of the talk that I plan on giving. So there's an intro to Alzheimer's disease, just a little bit on the discovery, some symptoms and whatnot. And then we'll transition to a little bit on risk factors and lifestyle modifications, and then current research and optimism in the field, just to kind of end us on a more optimistic, happy note. And this is all just in preparation for Dr. Garden's talk, so it's not going to be too in-depth, but just some surface level introductory things. So as I mentioned, here's our brief history. So it all kind of started off in 1906 when Alois Alzheimer's was presenting on his patient Augusta Dutter. And she had come to him with symptoms of paranoia, loss of memory, mood changes, and all of these things. And she passed away after 5 years in his care, but he was able to then look at her brain sections, and he noticed some very distinct pathological hallmarks, some things within her brain sections that allowed him to kind of classify this into a certain disease state. So he noticed these distinctive plaques, which we now know as amyloid beta plaques, and also these neurofibrillary tangles. And so he spent the rest of his career kind of researching these dementia and other forms of neurodegenerative disease, and really kicked off the field that I'm happy enough to be in today. And so Alzheimer's disease is a pretty difficult disease to study. So over the past 100 years, even though we haven't really been able to look into the brains of living people in great detail, we've been able to look and find genes that are associated with disease onset and find a lot of biological pathways that can lead to disease progression. And one of those hypotheses can kind of be summarized in this image, where we have amyloid beta plaques, which Dr. Alzheimer had discovered, can possibly lead to this chronic state of what we can call neuroinflammation. And over years to maybe decades in some patients, we can eventually lead to the development of those neurofibrillary tangles, those neurofibrillary plaques, tangles. And so we all might be familiar with inflammation as a broad term, but generally that's when the immune system is reacting to some sort of stimulus. And in the short term, that's really positive, right? So if you get a bacterial infection, you want to clear that out. But if that's a chronic state, so if you're not able to clear out this stimulus or this bacterial infection, then this can lead to damage within your local tissue. And so in the brain, you can imagine that that might not be great, right? So if we have this chronic inflammation within the brain, this is hypothesized to potentially be leading to the development of these neurofibrillary tangles. And so what is Alzheimer's disease then? It's considered to be an irreversible disease resulting from neurodegeneration, from the death of your neurons in your brain, the brain cells, right? And so it's characterized by brain shrinkage, loss of brain matter, and amyloid beta plaques, tau tangles, and neuroinflammation, which I've mentioned previously. And so here on the left, we have what we could consider to be a normal, healthy brain. So you see it's nice and full, really capable of doing calculus and all these hard math problems, right? Maybe. And then we have a brain that has been plagued with severe Alzheimer's. So you can notice very much that it's been shrunk, and there are these crypts and just a lot of loss of brain matter, unfortunately. And if we were to look into it, we might see amyloid beta plaques, as Dr. Alzheimer had noticed previously, along with these tau tangles. Now, one thing I want to point out is that we all can develop amyloid beta plaques just as a normal process of aging, but that doesn't necessarily mean you're going to develop Alzheimer's disease. But something along the way can possibly lead to this transition to the development of these tau tangles, which the field is starting to consider might be correlating with disease severity and symptom severity. So some symptoms of Alzheimer's disease, which many of you might be aware of, there's prominent short-term memory impairment. So it's difficult for individuals to transfer new information from their short-term memory into their long-term memory, and even to use new information that they've learned and apply it to certain scenarios, right? There can also be the development of language deficits, which can lead to a lot of frustration, because if you've ever been super tired and not been able to express your thoughts, that can be frustrating for you and for those around you, right? And there can be associated mood disorder or mood changes, behavioral changes, and as well as progressive cognitive decline over the years that you might be suffering from this syndrome. So some statistics now. It's estimated that approximately 1 in 9 Americans over the age of 65 has Alzheimer's disease or some form of dementia, and that equates to roughly 6 million people in the US right now. AD is currently the 7th leading cause of death in the United States. It used to be the 6th, but was bumped down one spot after the COVID pandemic. And unfortunately, by the year 2050, this incidence is expected to more than double to approximately 14 million individuals, as our medical innovations are able to keep individuals longer and as our population continues to age. And that can be a problem because Alzheimer's disease has a tremendous burden on the healthcare system. In 2020, it was estimated that there was about $300 billion of direct costs related to Alzheimer's disease, but this doesn't even begin to take into account the indirect costs of informal care provided by family members of those with Alzheimer's disease. And that's estimated to be a loss in GDP of approximately $244 billion because these people who are taking care of their family members are unable to work. So now let's talk about some risk factors and lifestyle modifications that we can all kind of think about to possibly improve or even decrease the risks of Alzheimer's and or of developing Alzheimer's in our lives. So above all else, age is the biggest risk factor for developing Alzheimer's disease. But there are other factors such as your genetics. Maybe some of you have heard of the ApoE4 gene. Chris Hemsworth was actually found that he had 2 copies of the ApoE4 allele. And this unfortunately increases his risk for developing Alzheimer's disease pretty dramatically. But that doesn't mean he will develop Alzheimer's disease. Again, this is all just risk, right? So just because you have any number of factors, that does not mean you will develop a disease. It's all kind of chalked up to probability, and you can always do things to try and help yourself. ApoE2 is a variant of this gene that is thought to maybe decrease risk of disease. And as we're talking about genetics, of course, then family history can also come into play. So if you have a first-degree relative, meaning a sibling or a parent who does develop Alzheimer's disease, this is also thought to increase your perceived risk of developing Alzheimer's, because not only do you share genetic factors with them, but you also might be sharing environmental factors. So you might be in the same household, exposed to the same things, exposed to the same nutrition and all of these things. So these are all just risk factors that we can't necessarily change. But now we can move on to modifiable risk factors. So these are things that we can all choose, right? So choose to do with our lives. So one of those, smoking, we might not be surprised at this point, right? Smoking increases the risk of developing so many diseases. And so the fact that it increases the risk of developing Alzheimer's isn't necessarily surprising. Poor nutrition can also increase your risk along with diabetes, excessive alcohol consumption, high blood pressure, cardiovascular disease, and maybe not surprisingly as well, head trauma. But now on a little bit more of an optimistic note, what can we do to decrease our risk, right? So if you are a smoker or you drink a lot of alcohol, you can try and cut down. I know it's really difficult, but those are things that can help, right? Consistent exercise is one of those things that has been found to possibly be neuroprotective in the development of dementia and neurodegenerative diseases, along with a healthy diet. And 2 other things, keeping your brain active and staying social. So doing those things that can stimulate your brain and keep you engaged, continue learning, just doing things that you like so that you're constantly challenging your brain to take in and process new information has been seen to be possibly neuroprotective, right? And staying social, what do I mean by that? You really just talking with people and interacting with folks, because social interactions are a very cognitively demanding behavior. And so if we can, again, just keep your brain active, that can possibly be a neuroprotective behavior that we can all take into account. So now some diagnostic things. So what is a disease biomarker? So a disease biomarker is some biological difference or molecule that we can use to kind of track whether or not an individual has a disease, and if they do have a disease, how far progressed they are in that disease, right? So one of the easiest ways, we've probably all had a blood test at some point in our lives. Blood tests are great for diagnostics. As far as I know, currently Alzheimer's doesn't really have great and reliable blood tests. So there is a lot of active research in that field to develop reliable, sensitive, and relatively cheap blood tests to detect some biomarkers for Alzheimer's disease. Your doctor can take your vital signs. Something that's used a lot in AD diagnosis is medical imaging, such as MRIs and PET scans. And so speaking of, we have up top an MRI where we see a cognitively normal or a healthy individual. And as we move to the right, you can see this brain shrinkage that I mentioned earlier. And then you can also undergo a PET scan, right? So PET scans can allow us to look at how efficient your brain is at utilizing energy, such as glucose. We can also visualize directly amyloid beta plaque burden and tau burden. So up here, like I mentioned earlier, amyloid beta plaques can be seen in healthy individuals, right? It is just a part of aging. But in these AD patients, we see that it's much, much greater in quantity, as well as with this tau pathology here. And so now on a hopefully more optimistic note, so treatments for Alzheimer's disease has historically not been excellent, right? We've only really had medications that have been able to reduce symptoms and just manage symptoms. But relatively recently, we've been able to develop monoclonal antibodies that are able to reduce amyloid beta plaque burden. Aducanumab, which I don't know as much about. I know it was relatively controversial at first, but then lecanemab, which has been able to both reduce amyloid beta plaque burden and tau burden, as well as result in some improvements. I don't know how significant, but improvements in symptomology in AD patients. So it's a pretty nice optimistic light at the end of the tunnel that maybe the battle is starting to turn the tides. And currently in development, there are a lot of labs racing to develop monoclonal antibodies that can target tau. I should have explained what monoclonal antibodies do, but basically they're antibodies that we make that are able to target something like amyloid beta plaques or these tau tangles and signal to the immune system to break down what they bind to. So in developing these monoclonals, we can hopefully reduce this pathology and improve disease severity in certain patients. I also mentioned that neuroinflammation is a part of the hypothesis that might be leading to the progression of Alzheimer's disease. And currently there's research into anti-neuroinflammatory drugs that hopefully if we're able to combine all three of these things in the future with some drug cocktail or just some treatment regimen, we might really start to, after 100 years of battling Alzheimer's, be able to reverse the tides and hopefully start winning. And with that, I have maybe some time for questions. I'm not sure.
I get all the slides and everything, but
Mhm.
is it always kind of stand out that dementia starts first? I mean, dementia is kind of a broad term.
Mhm.
And I can't remember the next day that I went to my room what I was
Right.
looking for, but I know I don't have any issues at this point, but is it always the first step, or is Alzheimer's very first slide show the woman who came in with all these terrible, and in 5 years she was gone?
Right.
I don't know what to look for.
Sure. Dr. Garden can talk a little bit more about that. She is a phenomenal physician. She's a neurologist. But yes, so I'll leave that on a cliffhanger if that's okay. Sure. Anyone else? Oh gosh, Monish, what's up?
I should know the answer to that, but you said this is the sixth leading cause of death.
Mhm.
What is the complicating factor that ultimately results in the death?
With Alzheimer's disease? Dr. Garden can probably also answer that to a little bit more depth.
Most patients pass away because they stop either they stop eating,
Yeah.
or they develop oftentimes they develop gait problems and will have falls that put them in the hospital and lead to them dying due to hospitalization and infections and things like that. And then sometimes they develop swallowing problems and they get pneumonia as a result. So many just stop eating.
Oh, yes. So the previous question was, what is the ultimate cause that leads to death as a result of Alzheimer's disease? And Dr. Garden, I don't know if you guys heard, but she mentioned that several things can result. So a lot of times patients with Alzheimer's disease will unfortunately stop eating. They can develop gait problems or walking, difficulty moving that can lead to falls, leading them to be in the hospital for extended periods of time. They can also choke on their spit and develop pneumonia, unfortunately, as a result of difficulty swallowing, amongst other things, I'm sure. Yes?
I would imagine accidents and stuff like that.
I'm sorry, I didn't pick.
Because typically in stages, people are in some sort of form of 24-hour care. So
Yeah, they're 24-hour
Yeah.
care, but if they're relatively untreated, I mean, does everybody with Alzheimer's get 24-hour care?
well, in the United States, probably the majority of them do. But not, but you're correct, there are some people who definitely, sometimes people escape their environment and wander, you hear about that on the news.
You showed some MRIs and PTs of Alzheimer's. Do you have a comparison of that and dementia?
So
Yeah,
I should have elaborated a little bit. Yeah.
I'll-
Yeah.
Dementia, so we-
Maybe,
not, but we'll talk.
How long has Alzheimer's been around? It sounds like we identified it around 100 years ago. Did it develop shortly before that with some kind of environmental push, or has it likely been around a lot longer?
I would guess probably. Oh, yeah. So the question is, how long has Alzheimer's been around? I don't think there's any way to really like definitively know the answer. I would guess that it's probably been around for as long as people have been around. I mean, again, being the common factor being aging, right? So it's just a lot more prominent nowadays because people are living longer and we've been able to kind of see that syndrome.
would that be conditional on what causes violent shape to increase? I mean, if modern technology, modern age processes the last 125 years,
Mhm.
there's something about the process of diets changing or work ethics changing,
Mhm.
something else changing, maybe even modern shape. The more information, maybe that's created more use of those modern shape created.
Yeah, it's certainly possible. I think we can definitely talk later. I mean, I love to have these conversations and just to explore things, but it's really hard to say at the moment. But we can talk afterwards if you're more interested. One more, two more questions. I think we can limit it to that. Yes. Unfortunately, as far as I know, women are affected by Alzheimer's more than men. I don't quote me on this. I think it might be like two times as much.
It's about 60, a little bit over 60%.
Yeah. Oh, the question was, are women affected by Alzheimer's disease more than men? And the answer is unfortunately yes. And one more, and we can maybe squeeze you in. We'll see. Sorry, but we'll cut it off after that. Ah, yes. It was something I wanted to talk about, but didn't really think. I kind of changed my mind mid-talk. But essentially, this is a diagnostic region. If we see that there's less glucose metabolism in these regions, that can be a diagnostic tool to indicate that possibly Alzheimer's is there. It's just another tool that would be added to the clinician's picture of the patient to kind of make their decision. And last one. That's an excellent question. So the question was, Alzheimer's disease being such a sensitive issue, how do we go about undergoing research in short? Well, because it's such a burden and kind of like could be described as an emergency, right? To try and figure out ways to treat it. And the fact that there is just so much funding for it. A lot of people care about Alzheimer's disease because probably everyone in this room might know someone or know someone who has dementia or some other form of Alzheimer's. And so there's just a lot of interest and to try and find a cure or some treatment, right? There are many models that we can use to try and model Alzheimer's disease in many different avenues, but we can talk more about this later if you're interested. Okay. And with that, I will let Dr. Garden go. Or are we taking a break?
Yeah, we'll take a short break. And I'll just come back again at some
Okay. Hello, everyone. So we're gonna get started again. So I'd like to just do a brief introduction of Dr. Gwenn Garden. So Dr. Garden is currently the H. Houston Merritt Distinguished Professor of Memory and Cognitive Disorders, as well as the chair of the Department of Neurology at UNC. She is also the co-director at the Duke UNC Alzheimer's Disease Research Center. Very impressive. She obtained her MD and PhD at the University of Washington School of Medicine and completed her residency training from Brigham and Women's Hospital in Boston, Massachusetts. Dr. Garden is a board-certified neurologist whose research focuses on neurodegenerative diseases such as Alzheimer's, with the hope of uncovering the molecular mechanisms that lead to the progression of these diseases. And with that, Dr. Garden.
So thank you for giving me this chance to talk to you today about Alzheimer's disease. And we're going to go over a few different topics. Oh, it's, I guess this way. No, I'll do it here. Oh, okay. All right. So we're going to touch on a few different topics today. And some of them Kyle already has been kind of covering. And so we'll go through some things quickly. And then those 4 topics will be kind of an introduction about dementia and how that, as a big topic, involves Alzheimer's disease, which in many slides I have abbreviated to AD. And then how we use biomarkers to diagnose it. We'll go quickly through that since Kyle did cover a lot of that. I'm going to talk a little bit more in depth about treatment and what the current landscape looks like, and then a little bit more in depth about dementia prevention as well. Okay, so we're going to skip that. I think Kyle did a good job. All right, now, Kyle also did a pretty good job about talking about what Alzheimer's disease is, so we can go over that. Now, here's where I wanted to go a little bit more in depth. So Alzheimer's disease is one type of pathology. It involves the very specific things Kyle described: beta amyloid plaques, tau neurofibrillary tangles, and neuroinflammation. But on this slide, you can see there are some additional types of pathology that have been more recently identified as strongly associated with dementia. And what we are more and more coming to realize is that many people with dementia have a multitude of these different pathologies. So it can be the case that if you have dementia and at the end of your life, you donate your brain and we go and we look in your brain, we will find that you had clear Alzheimer's disease pathology, but you also had some synuclein pathology, and synuclein is associated with a kind of dementia that we call Lewy body dementia. I don't know if anybody's heard about that. That's what Robin Williams had. And so some people have mostly Alzheimer's disease and a little bit of synuclein pathology. Some people have mostly vascular pathology. They may have had high blood pressure throughout their lives, maybe a few strokes. And then on top of that, they might have a little bit of Alzheimer's pathology, or they might also have a little bit of this kind of pathology, which is the accumulation of a protein that has this very glamorous name called TDP-43. And TDP-43 is interestingly a protein which is also associated with abnormal accumulation in patients who have ALS or Lou Gehrig's disease, but it can also accumulate in the brains of patients who have Alzheimer's pathology, who have vascular pathology, or sometimes even just by itself. And in a particular kind of case where TDP-43 is the dominant problem, those patients tend to present much later in life, 80s to 90s, have very specific kind of decline, which is much more focused on memory. Their pathology is much more localized to regions of the temporal lobe that are associated with memory, and we call that disease late. It has a whole new name, late. So some people who in the past we might have thought had Alzheimer's disease turn out to actually have something called late. And then there's tau. Now, tau, you may have heard, it can be associated with a different kind of dementia called chronic traumatic encephalopathy. That's the dementia that athletes who have repetitive head injuries can develop. And in those patients, they have accumulation of tau, often only tau, no amyloid, no TDP-43, no synuclein. They tend to be very young. Obviously, you've probably heard about, some of these very young athletes who have this CTE and often die by suicide. Then you also have people who have something called frontotemporal dementia, who can have pathology, which is only tau, but it's a little bit of a different form of tau than people who have CTE, and it's located in different regions of the brain. And those individuals may have genetic risk factors for frontotemporal dementia. About half of them do, about half of them don't. At least we haven't figured out what the genetic risk for that is. And they can have just pure tau pathology and develop this frontotemporal dementia. And that's presents in a little bit different way than Alzheimer's presents. And you may all know about Bruce Willis has been diagnosed with frontotemporal dementia, right? But the reality of today, 2024, is that we actually often don't really know all of the pathology that an individual might have when they develop dementia, right? So sometimes the clinical syndromes give you a lot of clues. Sometimes the individual's genetics can give you a lot of clues. Sometimes their exposures, like repetitive head trauma, can give you a lot of clues. But many times we just don't know, and we can be surprised when we do autopsies on patients and find out that they actually have a multifactorial dementia. So I wanted to just explain that so that people can understand that why these diagnostic tests are so important. Because you could present with dementia and there could be treatment that's aimed specifically at amyloid, like the lecanemab that was already mentioned by Kyle, right? Well, you're not going to benefit from that treatment unless you actually have high accumulation of amyloid in your brain, right? So we have to have good diagnosis to figure out who should get what type of treatment. And there are treatments that are being developed for all of these different types of pathologies. So hopefully for the young people in this room, at some point, if you come to your doctor with some memory problems, there'll be a whole bunch of different tests that they do. And then they'll say, you need, a little bit of this treatment and a little bit of that treatment, because they'll be able to tell all the different things that are going on. Or maybe when you're 50, you need treatment A. When you're 60, you need treatment B. And when you're 70, you need treatment C. But that's the future. We don't have that today. Okay, so biomarkers. Kyle explained what they are. And then in Alzheimer's disease, how we use them. So we can get back to the question. Now, I don't have images to show you what these biomarkers would look like in people who have different types of dementia, but we can talk it through a little bit. So in the glucose utilization test, so that's the one, that's the two brains. See, I get my laser pointer. So this is what's called FDG PET. So it's looking at how the brain uses glucose. And one of the things that we can do with this particular type of test is we can say, well, where is the brain not using glucose particularly well? So in this patient, you can see it's mostly in the temporal lobes, right? And then up here, it's also in the parietal lobe. So these are just different regions of the brain. This part's called the temporal lobe. This part is called the parietal lobe. And the classic patient with Alzheimer's pathology typically presents, not always, but typically with decreased glucose utilization in the temporal and parietal regions. Now, if you have what's called frontotemporal dementia, you would have the decreased glucose utilization in the frontal region, right? And there are a variety of different specific regional variations that can actually help doctors diagnose what type of dementia a patient most likely has when you look at this type of a PET scan. Now, if you don't have Alzheimer's pathology, typically you don't have a high degree of amyloid accumulation in the brain. You can have some, just like Kyle mentioned, and that there have already been established age-appropriate norms for amyloid accumulation. So if you have no higher than age-appropriate norm of amyloid accumulation, and you have a frontotemporal pattern of decreased glucose utilization, and you have a tau accumulation pattern, which is here, see, this is mostly in the temporal lobes, but instead you would have more tau in the frontal lobes and less in this particular part of the temporal lobes, then you might have frontotemporal dementia. So we can use all of these different types of scans to try to help define what type of dementia a patient might have. I'm not saying that it is always easy or possible. Sometimes it gets very confusing. We definitely have had patients who haven't fit a particular pattern. And in those cases, we typically think that they probably have more than one type of pathology going on. Does that help answer the question that you had? Okay, sorry about that. So, okay, so we use these tests. We try to help figure out what type of dementia people have, but they don't always give us a completely clear answer. All right, we do have additional tests. And some of them are much more specific and can be much clearer in terms of trying to help us decide what type of pathology people have. So I want to talk about spinal fluid. Spinal fluid is very important because we can get more specific about the proteins that are abnormal in patients. So we can get spinal fluid by putting a needle into the area that surrounds the spine, take out some fluid, and analyze the abnormal proteins. And we can see that in patients with Alzheimer's pathology, they have reduced beta amyloid because it's being stuck in the brain. So you'd normally expect to see a certain level of beta amyloid, but it's missing because it's not getting out of the brain and into the spinal fluid. But tau is very interesting. In different types of dementia that involve tau, there are often different forms of tau. And those tau forms are different because they are modified by other proteins to have changes in where phosphate molecules are attached to different amino acids in the protein. And so each different type of disease that involves tau has been associated with different, what we call isoforms, or different versions of phosphorylated tau. And we can create tests for all of those different forms of tau. And so if you have Alzheimer's disease, we expect to see those Alzheimer's specific forms of tau. One example of that is something that we call phospho-tau 217. And what that means is that the 217th amino acid in tau has a phosphate attached to it. And that's one of the forms of tau that is more associated with Alzheimer's disease. So it can get quite specific, at least in the research setting, as far as trying to help diagnose what type of tau disorder people have. And I'm sure this is going to become much more used in the clinical setting in the future as well. Now, I wanted to also talk about blood. Now, blood is interestingly a great place to look for Alzheimer's disease. We have now 2 clinically available blood tests that can give us a lot of information, at least to help identify which patients might need to have a spinal tap, or might need to get a PET scan, or might need to be followed more carefully. They are about to hit the market. And so it is still in question exactly, how they will be used. It's still in question whether or not they will be cost effective, because anything new always tends to be expensive. But this is coming. And so, you know, I can imagine within the next few years, you will know people who will say, oh, I got the Alzheimer's disease blood test. And the reason these biomarkers are important, I want to explain to you this, and this was one of the other questions that came up earlier about what happens first. Okay, so in this diagram, you can see here is when the patient presents with symptoms, right? And typically, patients present with symptoms in a stage that we call minimal cognitive impairment, or MCI, right? And so they present early with their symptoms, but they're still functional. They sometimes can still do their job. They can still take care of themselves at home. They still cook, make their way to the grocery store, etc. But they're struggling and they've noticed some symptoms. So this is what we, in a graph like this, we're talking time zero is when people notice their symptoms. But many, many studies that have been done really over the last 25 years in a variety of different type of patient cohorts have shown us that these biomarkers are abnormal 10 or even 15 years before people develop symptoms. So the first thing that is changing is not the symptoms. The first thing that is changing is the protein becoming abnormal in your brain, right? So here you can see this deposition of amyloid. This is using PET scan, right? So the amyloid deposition is probably starting to go up as early as 20 years prior to people having symptoms. And here is the spinal fluid beta amyloid. It's starting to go down, and you can detect it reliably going down, 15 years before people have symptoms. And then here's this tau. This was an earlier study, so it's the total amount of tau in the spinal fluid starts to go up long before people have symptoms. Now with these phospho-specific tau ones, we probably have even better data. Now, let's, I can't remember what it was next. Oh, okay. So what's happened, since we have all these biomarkers and we know that things are changing in people before they have actually symptoms, then we have created this scheme, which is called the ATN diagnostic scheme. And A stands for amyloid, T stands for tau, and N stands for neurodegeneration. So you can divide people up into these different categories based on whether or not they have amyloid, tau, or neurodegeneration. So here's normal people, no abnormal biomarkers, normal cognition. They're in this group, ATN negative, right? And here's people with Alzheimer's dementia. They can be down here in these groups where they have amyloid and tau, with or without changes that you can see, because the neurodegeneration changes tend to show up the latest, but they clearly have dementia, right? And then you can have what I find to be the most interesting from a research standpoint is you have people in these groups where we call it preclinical Alzheimer's disease pathology. They don't have Alzheimer's disease because they don't have cognitive impairment, but they're having evidence of amyloid accumulation, or in this case, amyloid and tau accumulation, right? You can also have people with minimal cognitive impairment who have what we call prodromal Alzheimer's disease, who have evidence for amyloid and tau. And what's so important about thinking about Alzheimer's in this way is this is how you do research, right? Before we really had this, you could have people in all of these different groups showing up in a clinical trial. And it could be that if there were too many of these people in the trial, you couldn't really make any difference, right? So the trial would look like it didn't have any benefit. Or if there were too few of those people, then the trial might look beneficial, but really, did we know who was benefiting, right? Because maybe it was only benefiting people in a different group. So now we can categorize people into different groups. And when we do trials, we can try to figure out if there's really a benefit, and if so, for which group. So just to kind of reiterate that point, many of the trials that are going on right now for all the therapies that are being developed against these proteins are taking place sort of at this stage when people are really first developing symptoms. But in the future, we're hoping that we can actually design trials for people who are completely without symptoms and try to prevent them from ever developing symptoms. So this is why the identification of preclinical Alzheimer's disease pathology by biomarkers has such an important impact and so important to think about in terms of how we're going to develop therapies and hope that they will be useful for patients in the future. And one of the things I like to say when I put up the slide is, you know, are we ready as a society to walk into a doctor's office at age 50 and have someone say, would you like to be screened for your risk for Alzheimer's disease? And then the question really still is open. Should we screen everyone? Should we screen people who have a family history? Should people screen people who have genetic risk factors? And if so, at what age? Okay. And so then the other question that I like to ask is, should we be using these biomarker-based diagnostic approaches in the clinic today? And my answer is, for people who have symptoms, even the earliest symptoms, I say yes. Now, not everyone agrees with me, but treatment is available. You might not choose to have it. It might not be right for you. But if you don't really know where you are in the spectrum, if you don't get evaluated, it's very difficult to make an informed decision. The other reason is that earlier you figure it out, the earlier you decide, the more likely treatment will be effective. And I'll show you some more information on why that's the case. So what is this treatment? What's it actually doing? So it's a little bit of a cartoon to kind of show you what this amyloid actually does, right? So amyloid is this little protein. It's only 42 amino acids long. It's cleaved off of a bigger protein, and it doesn't stay by itself very long. It likes to associate. It's called amyloid because that's what amyloid proteins do. They like to get together and form multiple copies of each other into like well, they're called oligomers, right? Multiple versions of the peptide. And then those oligomers actually eventually become something insoluble, right? So proteins can be soluble, like dissolve in the solution of the cell, or they can become insoluble. When they become a fibril, they're considered insoluble. Certainly in the laboratory, they're insoluble. And in the brain, what you see of these plaques is there's a core, which is these fibrils, and then around the core are these oligomers, which are still soluble. And the idea was that these oligomers, and there are certain genetic reasons why there was a hypothesis that the oligomers were actually toxic to the neurons, or the oligomers were what was causing the neuroinflammation, and then the inflammatory cells were toxic to the neurons. So what lecanemab is an antibody, which is, something that all animals make antibodies to try to block infections, right? We've all learned about that from COVID, right? So, but you can make antibodies in the lab, and they developed antibodies that were very specifically designed to go after these oligomers. And so when the antibodies are present, binding with these oligomers, that will target inflammatory cells to come into the area and internalize and remove these oligomers as if they were a bacteria, right? So we're harnessing the immune system to try to remove these oligomers. And something interesting happened when we did that. Oops. First of all, the oligomers are actually, in and around the neurons, and they get removed. And so the neurons are hopefully functioning better. But also when you remove the oligomers, even the insoluble fibers start to become solubilized in equilibrium, right? That's an old chemistry term. Hopefully people remember that. And then they can actually be removed. So we didn't know that would happen, but it does happen with these type of what we call anti-amyloid immunotherapy, right? So quickly, I just want to talk to you about a couple results from trials using this type of immunotherapy. So the lecanemab, which is the one drug that has been approved by the FDA and Medicare, right? So aducanumab was approved by the FDA, but Medicare did not agree to pay for it. But lecanemab was approved by the FDA, and Medicare said that it would pay for people who qualify to get lecanemab. It's a long process. Anybody want to hear about it afterwards, they can talk to me. So lecanemab, this was the trial. They had about 1,800 people in the trial. It was all over the world, multinational trial. Everybody had to have a PET scan to show that they had amyloid, and they also had to have CSF biomarkers, spinal fluid biomarkers, that were consistent with Alzheimer's pathology. You also had to have cognitive impairment. And there was a range, and then they used a particular outcome, which is called the CDR sum of boxes. You don't need to really know what that is, but it's both a cognitive test and a functional test, right? So it's looking globally at many of the different things that Alzheimer's patients have to deal with. And that was what was considered the primary endpoint for this study of lecanemab. And here is the primary endpoint results. And you could see that patients who received lecanemab did better than the patients who were treated with placebo on the CDR sum of boxes. Now, this may not look like a huge difference to you, but remember that the patients in this trial had both MCI and early Alzheimer's disease, and they were not necessarily evaluated for the degree of tau pathology that was already present. They went back to their data and showed that, first of all, even though the CDR sum of boxes is different, not dramatically different, but different, the amount of amyloid in the brain was dramatically reduced, and the amount of tau was also reduced. So I want to go to a little bit of a kind of going into another trial called Trailblazer, which is with a different antibody called donanemab. And in Trailblazer, they actually had quite a lot of their, started a little bit later, and they had quite a lot of the participants were evaluated for tau by both PET tau and this serum phospho-tau 217. And what they found in the Trailblazer study was that not only did it work just as well as lecanemab, but it worked the best on people who were less than 75 years old, who had low tau PET scores, and who had low phospho-tau 217. So what that says is that essentially, if you have less disease, you're going to do better with this amyloid-focused therapy than if you have more advanced disease. And they, oops, okay, hang on. Somehow or other, I screwed up a slide, but that's okay. Let me just go, well, we'll go here. Okay, so why not just give everybody who has amyloid these drugs? First of all, they're expensive. Second of all, there are real safety issues that have to be considered. So the first one is that a substantial portion of patients will develop ARIA. ARIA is called ARIA is short for amyloid-related imaging abnormalities. Many of you are probably thinking, who cares? Imaging abnormality, right? It's just imaging. And actually, in some situations, you don't care because people don't have symptoms. And actually, most people with ARIA don't have symptoms, but some people do. And when they have these symptoms, it can be quite difficult to manage because they can present as if they're having a stroke. And when you have a stroke, what do people want to do? They want to give you blood thinners. And what unfortunately happens is that some people with ARIA have something that we call ARIA-H, which is small hemorrhages. And so you really don't want to be giving people blood thinners when they are taking these anti-amyloid medications. Because what happened in a couple of cases is that people got given these really rapidly active blood thinning medications and they had hemorrhages throughout their brain and unfortunately died. It's only been a few cases, but that's the risk. Okay, so last slide. We talked about these trials that were done in this group of patients. But now they're doing trials in this group of patients. And the hope is that if you can actually remove amyloid early enough, you'll both reduce the risk of ARIA, because ARIA is really thought to occur because as the immune system is removing amyloid from the plaques, it's causing an inflammatory reaction in people's blood vessels in the brains. And that is resulting in this, it's a temporary state, but for some months, maybe even up to a year, people have this increased risk of bleeding in the brain because of this process of removing the amyloid from their brains. So if we can do it earlier, when they have less amyloid and before they ever have any tau, then it could be safer and more effective. And so those trials are actually happening today as we speak. That's really, I can go on about dementia prevention, but Kyle covered most of everything that I was going to talk about. There's only one thing I wanted to mention, which she didn't really go into, and that's sleeping. So I would probably tell you the most important thing that you can do, all these students here, the most important thing you can do as a middle-aged to older person is to sleep. Because it turns out that your body's normal mechanism for removing amyloid happens while you sleep. And there is a clear relationship between people who have either sleep apnea or insomnia. They have a higher risk of dementia. So both being short of sleep itself and the risk of accumulating more amyloid contribute to a higher rate of dementia in people who really don't sleep. And there's lots of studies, like this is just one study. There are many other studies that show this in all different kinds of non-sleeping situations. So manage your blood pressure. Stay socially engaged, exercise, eat a healthy diet, but most importantly, sleep. And I'm open to answer any questions. Go ahead.
I've heard great things about this Duke UNC Alzheimer's Center. Can you tell me anything more about it?
So, okay, thank you. That's a plan. That's my husband. But so we we have a Duke UNC Alzheimer's Disease Research Center, and what that is it's one of a large number of facilities around the country that are funded by the NIH to follow people over long periods of time in a prospective trial. And we are enrolling people as young as 25 and as old as 80 into a number of different cohorts. And if you are in any way interested in participating in Alzheimer's research, I would encourage you to go to our website and look into whether or not you want to participate in any of the research activities. For students, we also have something called the Ideas Forums. The students who are interested in doing Alzheimer's research, there's a monthly trainee focused seminar series that's actually run by trainees that are at Duke, UNC, but also UNC Pembroke, ECU, NCCU, and UNC Wilmington. So students from all over the region are involved in this symposium, and we have an annual symposium for presenting research on Alzheimer's disease as well. It's going to be at NCCU this year. Any other questions?
Quick question on the system differences between Alzheimer's patients and I guess people without it. So if they say everyone flags develop everybody, what is missing or gone in the immune system of something called Alzheimer's? Where we
Yeah, so the question is, why does the immune system fail to remove plaque in people who develop Alzheimer's and remain effective at removing plaque in people who don't? So Kyle mentioned a genetic risk factor, ApoE4, and one of the things that is hypothesized is that ApoE4 is something that modulates the ability of the immune system to participate in plaque removal. There are other genes that have been identified that have they're high prevalence but low additional risk. So we find them in something called a genome-wide association study. And so many of the genes that influence Alzheimer's risks that have been found in these genome-wide association studies actually influence immune function. So for people who have a family history of Alzheimer's disease, it's probably, and then develop it, it's probably likely that some of that loss of immune function is due to altered genetic factors that influence how your immune system functions. But, you know, sleep is another big modulator of immune function, right? Kyle put up some other environmental risk factors that are associated with Alzheimer's disease, and many of them probably influence immune function. So, and then, you know, we could go on about exercise and diet, et cetera, and then aging, right? We all have heard about inflammaging and how the immune system changes as we age. So the hypothesis is that it's a multifactorial change in the way the inflammatory system responds to amyloid. That's the kind of consensus hypothesis right now. Now, of course, there are autosomal, we didn't talk about this at all, but there are autosomal dominant genetic factors that can cause everyone who has them to develop Alzheimer's disease. And in those people, they just make too much amyloid, right? And those are, or their amyloid is somehow or other misformed. So they can be mutations in the gene for amyloid, or they can be mutations in the enzymes that cleave the amyloid off of the precursor protein. But that's, in those cases, probably not necessarily just an immune dysfunction, but actually in the amyloid regulation itself.
So I think for a lot of people, the question is, what is the fine line between normal forgetfulness, normal loss of words every now and then, versus a progressive dementia? And so before one engages the healthcare system, as a neurologist, can you tell us something about what we should look for at home for?
Yeah, so okay, well, I'm going to say the answer that I always said, but you know, I want you to understand, Monish, that really what I think is that everyone should actually be screened, and actually Medicare thinks everyone should be screened. So you actually, that there is a Medicare screening exam, so everybody 65 and over should be screened. I forget how frequently, with a cognitive assessment, right? But if you don't like going to the doctors, or you're not yet 65, I would say that the things that make you more concerned than regular forgetting why you went into the room to get something, is it's not that you can't remember something, but that you don't remember that you were supposed to remember it, right? So a good example would be somebody who has MCI is confused when you say, I just told you that we were going to be doing this on Tuesday. Right? They're like, oh, it's Tuesday. Am I supposed to do this? And you're like, yes, I just told you 3 hours ago that we were supposed to do this on Tuesday. And you feel like you don't remember that conversation at all. Right? That's that kind of level of, you really are not, it's not that you can't retrieve it in the moment, but you really don't remember it. Those kinds of experiences would be like, maybe that's something that needs to be evaluated. Does that help?
I think that's all the time we have questions as we hear the library making announcements. Really quickly, Dr. Matson is going to come up to make an announcement. Thank you so much, Dr. Gwenn.
Okay.
Oh, no, you're fine. We don't need 15 minutes, so we have plenty of time. Yeah, that's the site. It's right there.
Oh,
Yep,
wow. Okay,
it's
cool.
already up. Yep.
Think we're sharing
I think
still?
you just have to present.
I think if you
No, what do I have?
or start the
If you just
presentation.
click presenter mode.
That right there.
Let's see if that works.
There you go.
Cool.
Perfect.
Well, it's a little small, but we have hard copies too. Hi, everyone.
Why now? I thought I was dessert.
Oh, I'm not here to say that. I love dessert more than anyone, trust me. My name is Brooke Matson. I'm an alum of the MD PhD program, so I've been here for a long time. And mini med school was actually started when I was in the program. So I'm so glad that it has survived COVID and is still continuing. So thank you all for being here, and thank you for being on Zoom. And thank you to you all for giving us just 1 or 2 minutes of your time to plug our study. I'm now an endocrinology fellow at UNC, which means that I take care of people who have some of these risk factors for Alzheimer's disease that we've talked about, including diabetes and obesity. And I do research with Dr. Janice Wong, who's there in the back, if you raise your hand. And I just wanted to take 1 minute to tell you about one of our research studies. If after hearing from our speakers tonight, you're excited about maybe participating in some research on Alzheimer's disease. And Kyle and Dr. Gardner actually set the stage beautifully for our study, I think. You heard about the ApoE gene, you heard about different ways to take pictures of the brain, you heard about changes in glucose utilization or how the brain uses sugar. And most importantly, you heard about how a lot of these changes may happen years before people start to notice changes or family members notice changes. And so for our study, we're actually looking for younger people who are healthy and between the ages of 30 and 55 to participate in one of our studies on the UNC campus. And if you think that you may be interested and qualify for our study, we would love to talk to you. There are a couple of different ways to contact us. You could take a picture of this with your phone. We have hard copies of this flyer that's projected up here on the table if you want to take a copy on your way out. Our study coordinator, Joe, couldn't be here tonight, but his email is on this piece of paper. If you want to reach out to him to learn more, I'll stay behind for a couple minutes until the library kicks us out. And then in the follow-up email you'll get after tonight's session, there'll be a link to our study website too, and you can put your name and your email address there, and we can contact you that way too. 30 to 55. Oh, it's just hard to see. Oh, I apologize. Oh, thank you so much for pointing that out. I apologize. 30 to 55. Thank you for pointing that out. The hard copies are correct. Thank you. So I won't take up any more of your time, but thank you so much.